Hello, this is Dr. Bhaumik. Uh, I am the ex-professor of University of South Alabama and chief of the pediatric endocrine division, and also retired colonel from United States Air Force. I hope you are doing well. Those who are following my lecture, I appreciate that. Today, I'm going to tell you something which is very interesting. When you are in tertiary medical center with pediatric intensive care unit, you're bound to see some patient which really make you nervous and you remember them for a long time. This patient was such a patient. Uh, just a little bit back on the history. I got a phone call from community hospital about 30 miles away, and the physician from the emergency room was very concerned that they have a patient with new onset DKA. But that is not that concern because the fact that they see DKA and transfer to our hospital so frequently. But this patient, the child, not only had DKA, also has severe hypernatremia and blood glucose in the range of 175 or so, and blood sugar more than 1000. So that was very concerning. And I talked to my PICU attending and transferred the patient immediately. And I also went to the hospital because this is something is not very common. However, we did report 7 cases in endocrine practice with severe hyperosmolar hyperglycemic crisis, and they all had hypernatremia, but not to the degree that I am going to tell you today. So this with me, a third-year med-ped student who was working with me is very brilliant, and she deserves equal credit in solving the problem and managing this patient as well. So my goal today is to present a patient with DKA, which is rather severe, with severe hypernatremia, discuss main causes or many causes, whatever it is, or hypernatremia in DKA, possibly cause of hypernatremia and the degree of severity in this patient. So this was an 11 years old African American female who was presented with severe new onset diabetic ketoacidosis, and according to the mother, she has lost about 20 pounds of weight. As usual, like many DKA, she had vomiting, abdominal pain, decreased sensorium and decreased mental state. Only sibling in the family, otherwise has been healthy, no previous hospitalization. Parents does not give any history of excessive drinking of the carbonated or soft drinks. She's not taking any medication. The family history is positive for father who has type 2 diabetes. He also has hypertension. Mother seems to be in good health. The physical examination, she is very ill perfused, dehydrated. Her cap refill was more than 4 seconds, and she could barely speak. Mouth is very dry, but surprisingly, she is aware of her surrounding. She could say that she is in the hospital, and she could identify us as a doctor and also recognize the parents and asking for water. Her weight was 49 kg, 49.5 kg, and height is 151.4 centimeter, both on 75th percentile. Given the history of 20-pound weight loss, if we put it together, so she was on the heavy side. She has a typical cautional breathing, acidotic breathing, low-grade temperature, and she is in early puberty. Physical examination, obviously she is drowsy, and as I mentioned, she does respond to the verbal stimulus, and her people reacted to the light, and she was aware of her surrounding. DTR was 2 plus bilateral and symmetrical. Admission lab did show her WBC count is high, 20.5, which is not unusual in DKA, 80% granulocyte, 20% lymphocyte. In our emergency room, in our PICU, her blood glucose was 1049 milligram per DL, serum sodium 177, and we repeated again the same one, which was 175, using the same sample, and if you correct for her degree of hypoglycemia, her corrected sodium is around 192, which is extremely high. Her serum potassium was 5.5, chloride 125, BUN 48, creatinine 1.9. These are all consistent with picture of DKA. Anion gap was 50, pH was 7.03. This is arterial pH, not venous, arterial pH. Elevated lipase, amylase, and mild elevation of liver function test, which is not unusual. Her anion, shows what we have here is a anion gap acidosis, hyperglycemia, hyperosmolarity, elevated BUN and creatinine. And typical electrolyte profile of DKA actually include hyperglycemia, hyperkalemia. Major sodium is actually on the low side or low normal, but correct sodium by using the formula that people use is usually within normal range. So in PICU, obviously we started her 0.45 saline. Insulin infusion started with 0.1 unit per kg per hour, and her blood glucose was monitored hourly and sodium every 2 hours. One nurse was assigned to her case. She has to take care of her, no other patient. Frequent neurological examination, close monitoring of intake and output, and we added potassium as per DKA protocol. I'm not going to discuss the DKA management. that much because that is something people know, but we are going to address mostly about her hypernatremia. What was our goal was to bring the blood glucose down by 50 to 100 milligram per hour, no more than 100 milligram per hour, because she is a very hyperosmolar state, and sodium would have to 1 milliequivalent per hour, and we titrated our fluid and the sodium content in the fluid and the glucose content in the fluid to meet that goal. Her acidosis we corrected in about 36 hours, and the sodium also come within upper normal range by 92 to 94 hours. And she felt better and recovered from this incident rather completely. I have here put the day 1 sodium corrected and measured, and this column is the blood glucose, and this is the measured sodium, and as you can see in 4 days, in about 96 hours or so, it was back to within normal range. Actually from 3 days it became pretty normal. And so the CO2 was, acidosis was corrected, and this is the effective osmolarity. And so this approximately, as I said, 12 hours time difference. Took a little bit longer period of time to correct this acidosis and hyperglycemia as well as hypernatremia. And that was our goal, is to go slow. So as she was recovering from her TKA and severe hyperosmolarity, we did other blood test, pertinent blood test, and that came back, and we showed her she had a normal thyroid function, T4 TSH, negative thyroid antibodies. Serum cortisol was 30 CPR-DL, which is appropriate for the degree of the stress. Islet cell antibody is positive. So is the glutamic acid decarboxylase, GAD, 23.2 unit per ml, and reference range is in the bracket. We also did a CT to make sure that there is no hemorrhage or any other pathology or cerebral edema, and that was negative. So when do you see hypernatremia and diabetic ketoacidosis? Number one will be when the free water loss is very, very significant, and so that there is more loss of water as compared to electrolyte, sodium especially. And usually extreme degree of free water loss is seen in hyperosmolar hyperglycemic crisis. These are the patients with type 2 diabetes, and it is now seen more in pediatrics because the obesity and family history is the other two that goes along with type 2 diabetes. Many a time they are ignored and they do not get diagnosed until they have this hyperosmolar hyperglycemic crisis, and their management is even more difficult if they present with severe hypernatremia, and they frequently do so and with hyperglycemia. And there is an Australian study, and there is a study even in this country, show that the children, when they have DKA or before they develop severe diabetic ketoacidosis, they are very thirsty. Therefore, they drink lots of carbonated water. Not the water in our country is going to be a soft drink, which has got pretty good amount of sodium. So they drink so much to compensate for their dehydration. They also have lots of sodium in their system that way. But here the history was negative. So here we are. In the beginning, since she was African American and black and also on the overweight side, the possibility of type 2 diabetes with severe hyperosmolar hyperglycemic crisis came to our mind. But we have seen many type 2 diabetes with hyperosmolar hyperglycemic crisis, but not to this extent, hypernatremia to this extent. And so we even got more concerned when we find out that this is actually type 1 diabetes because of positive ICA and GAN antibody. And so our feeling from the very beginning was it was type 1 because of her degree of acidosis and hyperglycemia, but this test, GAD and islet cell antibody, make the diagnosis rather easily. So now question comes, how often one see the type 1 diabetes with this degree of hypernatremia? With my practice in the military medical center as well as university hospital, over 40 years of experience, I really have seen many DKA in hundreds, many hundreds, close to 1,000, but I have never seen a hypernatremia of that degree in a patient with type 1 diabetes. So let's see that what happened next. Again, as I said, that this thing, dehydration hypernatremia can happen because of this reason. This slide has been duplicated, but it's just to emphasize. So this patient lab monitor in the hospital in sodium, potassium, CO2 was very good. Blood glucose remained normal in the hospital. An antibody test, as I have mentioned, has proven that this patient has type 1 diabetes, and she was discharged home in a week. Now this is where my very brilliant MedPed resident was talking to the patient, because we are puzzled by the fact that this patient, being type 1 diabetes, has this degree of hypernatremia. As she was taking history and was telling at the beside, this cough, cold medicine, anything else were you taking that you remember? Then she said, well, my parents were giving me a capsule that's supposed to help me not to go to the restroom that often. And this is a capsule, and I was taking one capsule 3 times a day. So when the patient came, parents came, we asked about this pill, the capsule. So both parents said, oh, I don't think it was medicine, we take it off and on. So That's what I really didn't know. We did not really volunteer that information. We really didn't think that it was medicine. What indeed they are giving, a product which is known as golden seals, which actually was not known to me before. And the name, the botanical name is Hydrastis candinensis, Hydrastis candinensis, or golden seal. It comes in a capsule, liquid and powder. It seems to be very popular, and this has got lots of property according to the pamphlet that takes care of the infection, especially urinary tract infection. Parents thought that frequent urination is the part of urinary tract infection, so start giving this capsule. The highest capsule is the 520 milligram 3 times a day for 2 weeks. And the family said that we use it off and on, and the patient has not used it before. So she was discharged home, and control was not very good. Hemoglobin A1C continued to be unsatisfactory, and serum sodium continued to be normal. She had a second admission in 11 months later. At that time, her blood glucose was 710, measured sodium was 132, and corrected sodium was 142. So this is a very typical picture of DKA, and she certainly was not taking a golden seal. So, hypernatremia of the degree of hypernatremia that we saw in our patient, we believe it was because of the golden seal. Now, second admission with DK without hypernatremia, without golden seal taking, actually support that concept. Let's see what we found about golden seal. This is widely cultivated in Oregon, Washington, North Carolina, Ohio Valley, and many other places. And it is a perennial herb with knotty yellow rhizome. I have a beautiful picture that I'm going to show you. And the dry part is that roots and the rhizomes is the active part. The dry rhizome and root is the active part. Now, scientists have shown, and it has been in the medical literature, the isoquinoline alkaloid, hydrostatin 4%, berberine 6%, and candian believed to be the principal bioactive component of this product, golden seal. So this is a beautiful flower that it comes when it blossoms. It's a beautiful flower, and this is the golden seal plant, and this is what is the medicinal value right here, the rhizome and the roots. This. So this use of golden seal is very well known. American Indians, they use this one for various purposes, mainly for intestinal ailments, arrow wound, insect repellent, eye infection, and anything that ailments will affect them. It appears to be the golden seal was the medicinal choice. The early settlers learned the use of this uh, golden seal product from Indians. And the scientific study, as I can go back and see, there are some studies done, and they actually did show that it has mild antibacterial properties against Escherichia coli, Proteus, Klebsiella, and very mild degree with the Staph aureus. It was documented by scientific literature. And so it probably does help, but it has very minimal uh, antibactericidal property. So although we knew about this from the family, the history now question is, how can you correlate the free water loss with golden cell? Until we found a ophthalmologic literature, eye literature, and where it was clearly written in that golden seal is an acuratic, that means it increase the diuresis, increase the water excretion through the kidney, but not sodium. So it retains sodium and dump free water. And in the product handout, it is written it is contraindicated in the patient with hypertension or patient who has been taking hypertension medicine, hypertensive hypertension medicine of any kind of medicine they are taking for hypertension, it is contraindicated. Prolonged use can cause edema and hypertension itself, and it is assumed to block the V2 receptor, that's the ADH receptor, in collecting duct, and therefore it dumps the sodium. The absorption of water from the collecting duct is interfered, and sodium absorption is not interfered. And the absorption of sodium mostly from proximal tubule. And now, if you look at this, this looks like a nephrogenic diabetes insipidus, where there is in nephrogenic diabetes insipidus is the insensitivity to ADAs, but in golden seal it is the same way, blocking the V2 receptor. So there was a big conference about this in Toronto. I'll put some reference in my section of internet where I usually put the comments. Showed that use of alternative medicine is more prevalent than the people like to see and know. And the use of alternative medicine has become more popular in this country. There are many young people now, they go for alternate medication and alternative medicine healer as well. And so there was a study by Dr. Abramson and his colleague found they studied 308 patients and found 45% use these alternative medicine or complementary medicine. So, but they do not consider that in the category of medicine, and therefore they also don't tell the physician when they ask question that are you taking anything else? And since we are the, the allopathic doctors, so they really probably don't say anything about that. And the patient, in pediatric patient, usually get from their parents, and it is believed that each alternative medicine they use is harmless. And now the source of information from the internet and the age of the great computer, internet, Facebook, all this thing, they talk about that, and they saying hear from the patient parents that their child had this and we took this product and they got better. So this is how the information get disseminated. So it is important conclusion that there may be interaction between this alternative medicine and they are not regulated by FDA, and therefore nobody is looking the properties of this medicine, I mean the harmful properties of this medicine, if they may have that. There may be interaction with the other medicine that we take for other disease in the modern medicine, and when our medical student or I myself start taking history, frequently don't ask about this, taking any alternative medicine or herbs that coming from Ayurvedic medicine or Chinese medicine and so forth. That information is necessary. That I'm not telling those are bad medicine, they should not be taken, but I'm telling that this information may be helpful if there is any interaction or any abnormal and unusual lab or chemistry is bothering, is coming to play. So therefore I thought this case will be interesting and helpful because of the fact that a primary care physician, just one question might help. And all these hundreds and hundred thousand up to thousand of this alternate medicine that in the nutritional stores and other places might sometime react with the medicine that we are taking, or it could cause in a higher dose some complication. So therefore, the point to be taken home from here is that we should make a habit of asking the use of herbs, roots, or any other medication or from the health store the patient is taking. Because what mind does not know, eyes do not see. The mistake that we made also, that we did not feel that was a problem, and we are asking and we are looking for the medical reason, but the reason was there. Only one good question, one selective question gave us the clue. Now the patient is doing very well otherwise, and second admission actually was made it clear she is not on golden seal. Her chemistry and profile, DKA profile was exactly like the way it should be. It is possible that normally when you are healthy, this golden seal or any product will not do any problem. However, she developed DKA. She was having already a problem which will compromise her blood glucose and electrolyte. And therefore, probably that broke, as we can say, the camel's back. But my main point here to emphasize that the information about the herbal medicine, alternative medicine uh, from the patient should be taking history should include that and should be asked. Thank you very much. And as I said, Dr. Handley, who was the resident then, is now Associate Professor of Medicine and Pediatrics, and she's also Program Director. And so equal credit should go to her. She's the one who actually find the information. Thank you again. My next presentation, there will be another very interesting case, and I will see you then.